Thank you. It's an honor to be here. I'm sorry, it's been a long week, so my voice is not as good as it was at the beginning of the week. But I definitely have lots of disclosures, and I am going to talk about stuff that I train on with, and I do consulting and training with Boston Scientific and several other endoluminal companies. So, if you think I'm full of crap, then you may be right. So, the other disclosure I would say is we're operating on a chronic disease, and you have to figure out how you're going to manage that. I think Joe did a great talk about, he explained very well about, the recurrent problem, and it has been hypocritical in our past when we say, well, this is a disease of physiology, and then the patient regains weight, and then they're just being, making bad choices. And I think we have commonly looked at this as a spectrum. You're either, just eating too much and making bad choices, or you're dealing with the physiology, which is a disease of abnormal hunger and metabolism. We're still not very good at getting across to the public that that's the problem. It's abnormal hunger. You reduce your calorie intake and you're hungry. You're physically hungry. But we're not good at describing what hunger is. Patients often don't know what hunger is. But that's what we're trying to really attack with our interventions. That's what we're trying to attack with the medicines. And we have to work on these because these feed each other. It's a cycle of, if you control hunger well, it's easier to make better choices. If you make bad choices, it gets harder to control hunger well. You have to keep working on both of them. And if someone gets way off the cycle, it's hard to get them back on. But I mean, if it's a chronic disease, we got to keep engaging. So we can't just use the excuse of, well, you're just making bad choices all the time. So I agree with Joe completely about that. And revisional patients are different depending upon the situation. And endoluminal therapies, there's certainly a sweet spot for them. You have the patient that had the bypass, they lost a bunch of weight, they've gained just a little bit of weight, they gained 15 pounds. That's different than gaining 50 pounds, and that's different than gaining back to more than they've ever weighed before in their life. They're different problems. You have to address this in a comprehensive model, which I think everyone who's come up to the stage already has said. You have to address all these issues around how well you're educating them, the psychological factors to eating, and then medically really kind of evaluate what's going on and seeing if you can't optimize them. One thing I get up here often and talk about is measuring someone's metabolism can really help you kind of guide as far as, what you're going to have to do. Because if a person has 1,000 calorie resting metabolic rate, and they do exist out there, you've got to get them chronically consuming 600 to 800 calories a day to lose weight and then maintain it. And we're off by our own calorie estimates, even if we're doing a great job, by 20%. We underestimate by 20%. So metabolic carts can really help kind of guide the patient. Now, if a patient comes into you and they have a 1,200 calorie metabolic rate, it really sucks to tell them that. But at the same time, at least they know, and they have more appropriate expectations, because you're going to have to potentially be more aggressive in your follow-up and your management. And then, of course, just leaning into all the discussions we've already had about how complicated this is. Some of these are about structural issues, some of them are purely about weight issues, and some of them are about both. So, I think Joe did a great job at talking about revisions with bypass, and I certainly do surgical revisions. I do biliopancreatic limb lengthening. I don't convert them to duodenal switches personally, because if they have reflux after that, then what are you going to do? So I tend to mess with biliopancreatic limb lengths. Sometimes I get them wrong, sometimes I get them right, but it's something that you can continue to revise. This is actually reasonable data that we don't look at because we've had such a slam against the ban, but there is reasonable data to ban a bypass as well. I just want to throw that out there, and you can look it up. But I'm here to talk about endoluminal suturing. I've already been talking for 5 minutes about surgery. So what about that? So certainly you can do it. It's been studied, and weight loss, long-term weight loss, correlates with outlet diameter more than pouch diameter. So when you focus on reducing, causing weight loss, you want to focus on reducing the outlet. That does have a positive effect. You can do it with medications like sclerosants, but it usually requires multiple treatments over short periods of time. Usually around 2 to 3, but you can get reasonable weight loss of about 10 kilograms. Think about 10 kilograms. That's kind of the standard thing you're going to hear when you hear endoluminal effects. So when you do suturing, almost everyone that does suturing does some type of cautery APC to sclerose the outlet as well. And then you use that to create your rim to perform suturing on. There's multiple suturing techniques. There are obviously whole courses on this, on how you do it. But your goal is to make it tight. And if you're going to get into this, and some of you may already have, if you really need to get the outlet down to less than a centimeter, 6 to 8 millimeters, which kind of freaks you out when you start doing it, is really kind of your goal, because it's going to dilate a little bit and the sutures do relax some. So you also need to put them on the same type of diet you put them on after a gastric bypass. And I put them on liquids, and I try to keep them on liquids for a minimum of 2 weeks, because you want to protect the sutures as best you can. And when you're doing the suturing, you're doing multiple figure of 8 or multiple sutures, and then you're over sewing on the pouch to try to reinforce those sutures. And then you put them on this diet, really trying to protect the outlet. And if you do all those things, you can have some reasonable results. If it works, you have good weight loss. If it doesn't work, you don't. So this is a patient, it didn't work. Everything's blown out at 3 months. Maybe had a technical issue, and they fail early. They get hungry early. They don't lose weight. But if you get a good result and your sutures hold and you manage the patient well and you warn them about this, what I say over and over to these patients is, this is not the second coming of a gastric bypass, but we're going to pretend it is, okay? We're going to do the exact same things. If you get them engaged like that and you get a good technical result and you get them engaged, you can have good results. And there's a lot of suturing devices out there. It's not just about the Apollo overstitch anymore. And actually they have 2 devices, but there's still the USGI device. It's a little bit larger. So for pure outlets, the overstitch device is still kind of the winner at this point, but there is the Endomina device, which also has a little bit of a larger profile, so it's harder to get into smaller spaces. But there are multiple devices being developed out there. If you compare between the devices, generally the best data is around the overstitch. This is just some of it, looking at large centers. You see this kind of 10-kilogram weight loss. And there is some durability. 18 months, it's around 8 kilograms. So, this is often, 15 to 30 pounds. And there is even some durability data on it over 5 years. But if you compare it to surgery, it's pretty similar, and it's much less risk. So, as opposed to just going and tightening up an outlet surgically, I think if you're going to tighten up outlets, do it endoscopically. I think the data more than supports that. Because it's just at a lower risk, significantly lower risk. Can you do it on sleeves? Yeah, you absolutely can. You got to do it aggressively, and you got to do it safely. But it will work in sleeves, but probably not as effectively, because you're trying to reduce the outlet. So it's more like an ESG of a sleeve. Can you do just APC alone? Yes. That when people didn't have access to these devices, they would APC it. And it's more variable in its effect. They would do it at higher wattage and higher flow rates to create more of a stricturing effect, but it does work as well, and that's been done in multiple countries. But obviously, for one last point, we're very interested in what you can do off of a sleeve. I think it was just presented very well, how sleeve to bypass, which is a nice, easy concept for us to embrace, actually doesn't work very well for weight loss. So some of these duodenal effects, if you're trying to add weight loss, and there's several of them out there. Obviously, we have the SADI and the switch, but also there's all these other procedures that are being talked about that have better diabetic effects. They have other potential risks. So can we do this endoluminally? And yeah, the answer is basically we can. I guess the video is going to work. But we have ways of now deploying magnets that are self-forming. And I do work with this company. It's called GI Windows. And there's another company called GT Metabolics, which Michelle Gagnes will talk about a lot. One's a bar magnet. This is a self-forming magnet. You can deploy them laparoscopically. You can deploy them endoluminally. And you can deploy them like in a duodenal ileostomy. You even can do an end-to-end, functional end-to-end duodenal ileostomy with some of these systems now. And so I think we're going to have safer ways of doing more intestinal procedures on sleeve patients as well. Oh, there it is. Okay. So you can deploy these with systems that actually capture your enterotomies or you can deploy them endoscopically. And these magnets will slough off in about a week. Sometimes they'll sit in the cecum for 3 to 4 weeks before you poop them out, but you do have a very safe and secure anastomosis. So to kind of summarize, if they have just a little bit of weight regain, I'm really thinking about endoluminal therapy. Obviously, pharmacotherapy plays in all of these realms. I really look for, what is structurally something we can improve if the weight loss is more, but I will consider endoluminal therapy in those situations. If they have a lot of weight regain, then I'm really looking hard into what their metabolism is, and then what can we do that's more aggressive than most endoluminal therapies. But some of these endoluminal magnet procedures that may be coming down the pipe, maybe that'd be something that we can work in that area. One last question, because people do ask, I have to talk about endoscopic sleeve gastroplasty all the time. Can you revise it endoluminally? Yes, you can actually re-ESG and ESG just like you can a sleeve. And it works pretty well. It's a pretty good engagement tool, similar type weight loss, but certainly something that's very doable. So I think everyone's been up here, will acknowledge most of this is a chronic disease. You have to keep working at it. I don't know how many times I say at every clinic visit, at least once a year for the rest of your life until we're all dead. You got to keep interventions available with medical treatment, and medical treatment's super important. But endoluminal revisions keep patients engaged in chronic care as well. And we have these patients that, for right or for wrong, sometimes it's an advantage, sometimes it's a disadvantage. It's just they're looking for the event. And if you can give them an event that's very, very low risk, you can engage them back in your entire process because they like the surgery idea. And maybe over time you can get them more comfortable with using other interventions, including meds. And I think we should try to help everyone we can as long as they're being nice. Thanks.